So we're on part 8 now. We are on safety and security needs. We have moved up the pyramid from physiological needs, which was a big chunk of what we were going to talk about. And today's lesson is going to focus on safety and security. Now, safety and security needs include the need to feel safe as well as the need to be safe. But for the reasons of time constraint and for purposes of building a knowledge base for you to work off of later, we're going to focus mostly on the physical needs of safety. And we're going to focus on risk reduction, which is a big part of NCLEX. And you'll see it a lot in your ATI questions, your unit exam questions. In one phase or another, in all areas of content, things are going to be focused on how to prevent bad things from happening to people. So our first learning outcome is going to involve applying the nursing process to the care of a client who is at risk for infection. And basically, when you work as a nurse, especially in an acute care setting, every client is at risk for infection, just by the fact that they're there. And so we're going to learn a lot about medical asepsis and surgical asepsis. And that content will be critical for you to learn because you're going to need to use it again in perioperative, in your perioperative content, which comes a little bit later this semester. And also anytime that you use, you learn a new nursing skill that involves sterile technique, and even skills that involve clean technique, we always want to be mindful of the fact that we don't want to cause infections. Infections in the hospital are considered never events. They are something that really, we should never be bringing people in for care and causing them to be worse. And so infection prevention is a big part of what you're going to learn. And remember also, you're going to pull in the things that you learned from your labs, and that will be featured on Exam 1's content. So the next objective that we have is to apply the nursing process to the care of a client who is at risk for injury. And most especially, we're going to fine-tune that to the process, to the nursing process of care of a client who is at risk for falls, because falls are a very serious occurrence that we're targeting nationwide. And falls in your frail elderly population very often lead to rapid deterioration of the physical condition and can lead to nursing care placement, or even, that downward spiral. They start with a fall, it leads to a hip fracture, then they get pneumonia, and then things just progress until that person's no longer living a meaningful life, if at all. So anyway, those are the learning outcomes. Now, your textbook resources are here. Wilkinson, Treese, Barnett, and Smith. Chapters 23 and 24, pages 516 to 573. Again, it always sounds like a lot. I am going to tell you that your textbook goes really far and wide with this, everything from fire prevention to gun safety and choking hazards and things like that. We will touch on them lightly. Really, we're going to look at the adult client who is hospitalized because that's where your clinicals are going to be based. When you get to peds, when you get to community, you'll revisit all these concepts. They're basic concepts and they come back again and again. But we're going to really try and focus our attention on things that you can use right away. Okay? And I'll guide you with the reading as we go along. Let's talk about some basic concepts of infection prevention, and you'll find that this is a big part of the nurse's job because the hospital is a place where patients are weaker, so we have a host that's susceptible, and the bugs are bigger and badder. They've been fed little bits of antibiotics, and in our environment we tend to run across a lot of those little superbugs that are very resistant to treatment. And so preventing infection is going to be an important thing that you need to learn. We'll talk a little bit about what never events are, because that also impacts on the next section that we do, which is going to be safety. Never events are things that should never happen to our patients in the hospital or in any healthcare setting. If people come to us for care to promote health or reduce risk or to restore health when they're ill, we shouldn't be making them sicker. And so the Center for Medicaid Services, or CMS, has decided that there are many healthcare-associated infections that are never events. For example, catheter-acquired infections. If you're putting a Foley catheter in somebody, there are steps you take to prevent infections. Infections from IV sites are never events. They should never happen to people. If IV therapy is the way that we're treating them, they shouldn't get sick from that. Central line infections, surgical site infections if you have an elective surgery. Now, if surgery is emergent, somebody's bleeding to death, or you have to do an emergency C-section. Surgical infections might be a risk that is more acceptable than having the patient hemorrhage or having their baby die. So elective surgeries at least follow a protocol to prevent surgical site infections. So those are some things that we keep in mind when it comes to infection prevention. We have, let's see, I'm going to start talking about the chain of infection because there are 6 links, any one of which, if you interrupt, you will break the chain of infection and hopefully prevent one. So we have first the causative agent. A causative agent is the microorganism. It can be bacterial, it can be viral, it can be fungal, it can be a protozoa, it can be a parasite, but these are the agents that make people sick. Causative agents can be strong or they can be weak. Hopefully we keep them fewer in number, and that prevents our, reduces our risk of infection. Sometimes the body can handle smaller numbers of the causative agent and it can't fight off larger numbers, and so we do what we can to reduce the risk. The reservoir is the place where the causative agent goes to hide and make little baby pathogens. Pathogen, by the way, is the word that means, I'm sure you remember this from microbiology. It's a bacteria or other organism that causes disease. Now, some microorganisms are completely benign. They don't cause any disease. They're just there. And some of them actually help us. There are bacteria in the gut that make vitamins. There are bacteria that crowd out the bad bacteria. And so we don't want to get rid of all microorganisms, just the ones that make us sick. Anyway, the reservoir is a place where those pathogens go and breed more pathogens. So a reservoir can be a host, and either the host has symptoms and is ill, or the host is asymptomatic and is a carrier of disease. A reservoir can also be objects that are warm, dark, moist, particularly if they have nutrients. For example, if you have food that's sitting out at room temperature and it's got plenty of proteins and sugars, and you let it sit out for 6 hours, that food will harbor microorganisms because the microorganisms will feed off of that, particularly if there's moisture. Now, nutrients like warm, dark, and moist. They like a temperature, consistent temperature around 95 degrees, give or take. They can usually live, I'm assuming that when you were in microbiology, you guys did some experiments with Petri dishes. Sometimes they can live at like room temperature. It really depends on the organism, but they don't like anything too cold. They don't like anything too hot. They like things that are around 95 degrees, give or take. So they like warm. They like dark. Organisms that are exposed to ultraviolet light very often will die. So keeping them in the dark helps them grow and breed. And they like moisture. Moisture helps their cell walls stay viable. If they dry out, their cell walls will dry out, and then they'll die too. So warm, dark, and moist, and like I said, nutrients for them to feed off of are particularly important. Remembering about the nutrients, I just want to throw this in there. Diabetic patients are really at risk for infection because the blood sugar feeds the bacteria, so that's important. Plus, in diabetic patients, their oxygenation and circulation, tissue perfusion is sort of limited, so the body's defenses can't always reach the place where it needs to go. Anyway, okay, so let's move on. Portal of exit. Portal of exit is the way out of the host and into another host. So we have under portal of exit things like blood, body fluids, saliva, mucus, feces, and urine, obviously. So all of those things, create that portal of exit. They're, sort of the doorway out. Then we have the mode of transmission. That's like the getaway car. So the force of the cough or the sneeze propels it through the air and makes it available to another host. Mode of transmission, there are a few. I'm going to shrink this down so that I can write some of them down. We have direct contact. I touch my nose, I'm sick with a cold, then I shake your hand before I wash my hand. That's direct contact. Indirect contact. I have a cold, I rub my nose, I touch my pen, I let you borrow my pen. I don't wash my hands, I don't clean my pen. That's indirect contact. And under that we also have droplet transmission. And that is, I cough, I sneeze, and little droplets that contain that cold virus or, whatever upper respiratory, if I have pneumonia, whatever, are now available to you, and you inhale them. But you need a water droplet for that. You need to be about 3 feet from the source in order to transmit or to receive that germ. If you are the one who's sick, stay more than 3 feet away from people, please. They'll like you better. Airborne transmission. This does not require water droplets. Airborne transmission is microorganisms that kind of go on air currents. And so that's why rooms for TB patients have like a negative pressure. They suck out the air so that it can be cleaned and recycled. So every time that you shake out a linen that's got germs on it, every time you sweep the floor, you're stirring up stuff, you can have some airborne transmission of particles. We have vector transmission, and the most common of this is like mosquito bites that give you Zika virus or West Nile virus. Insects, ticks give you Lyme disease. Fleas carried the bubonic plague way back when. So that would be your vector. If I get bitten by a bat who has rabies and I get rabies, that's a vector. So that's a little bit about the mode of transmission that you might encounter on your nursing journey. Okay, and then we can talk about portal of entry. Now we had a portal of exit, we need a portal of entry. So your body orifice, all your body orifices create a portal of entry. Your nose, your mouth, your eyes, your urethra, all of those things are places where germs can find their way into the human body. Thankfully, most of our orifices, all of our orifices, have some defenses, and I'll talk about that in a minute when we get to susceptible host. Now, those are the natural portal of entries. Portals of entry. It's getting a little bit late here, but there are some that we create when we insert an IV. We're creating a portal of entry because we're breaking the skin. The skin is the body's primary defense, and I'll cover that concept in just a minute. But whenever you break the skin, whenever you do an invasive procedure, if you suction somebody in their oropharynx or their nasopharynx or in their trachea, you now creating a portal of entry, a tracheostomy, any ostomy, any opening that we as healthcare professionals create in the body is a potential for portal of entry. And so we want to be very careful around this because the body didn't make defenses for an IV site. The skin was its primary defense, and you broke that down. So we need to be very protective of those things. Now we can talk about the susceptible host. Okay, I'm sorry. Susceptible host. Most people are immune to most things they encounter in their environment or have defenses against most things. Now, depending on what the organism is, what the body's experience with that organism is, and I'll talk about that in a minute, we talk about vaccines, and depending on how weak or strong that host is going to determine whether or not this person gets a disease. So some things that can make a host more or less susceptible, we'll talk about some factors that increase your susceptibility to illness. Developmental stage for one thing, and we're on page 528 of your textbook if you want to follow along. You're very old clients who are a little bit weaker physically, immune function declines as you age, are at risk. Your very young clients, children under the age of, say, 12, particularly infants and toddlers, are vulnerable because their immune systems haven't yet developed and they haven't been exposed to a lot of things. So they are also at risk. Anyone who has a chronic illness or injury, because your body's defenses are being taken up with the healing of that. People who have chronic illnesses such as diabetes or cancer who are being treated. Obviously, people who have immune dysfunction like AIDS or HIV. People with leukemia whose white blood cells are altered. Those people are more susceptible to infection. Tobacco use really damages the structures that defend the body against illness. So, when we talk about what things make the immune system a little bit stronger, that'll make more sense. Substance abuse leads to poor nutrition, leads to weakened immunity. So that can impact it. People with unsafe lifestyle behaviors, such as multiple sexual partners or sexual partners who are engaging in risky behavior. And then people have occupational exposures. I mean, obviously, if you teach at a preschool, children are little petri dishes. We all know that. So you're more at risk for certain infections. And then there are a lot of medications that depress the immune system. Most of your chemotherapy agents, steroids, which are very, very common, and even antibiotics, which treat infections, destroy those natural flora, normal flora, that creates a natural defense against other infections. And then, of course, we have breaks in the skin and breaks in or invasive procedures that we talked about. And those are things that make you more susceptible. Now, what are the things that make you stronger? Let's talk about the body's natural defenses against infections. So, primary defenses. And these are kind of the things that keep the bacteria or the other microorganisms from getting in. So this would be like the wall. If you built a great big wall to keep everything out, this would be what you're talking about. And the primary one is the skin and mucous membranes. You're going to be covering integument in this semester. And we talk a lot about skin integrity and wound care. So when the skin is broken, either from a surgical incision or if you have a wound, that was maybe a pressure ulcer or even anything that's invasive that penetrates the skin is going to make the body more susceptible to infection. So keeping an intact skin is important. Now your respiratory system has mucous membranes. There are little hairs called cilia that line the nasal passages and the bronchial tree. And we also have the natural defense of coughing and sneezing. When something tries to get down our trachea, we cough it out. When the body has inflammation of the respiratory structures, it will try and cough out all of that stuff. Now your eyes have tears, and tears have antimicrobial properties, plus they kind of flush out the invaders. Your mouth. You actually have a lot of germs in your mouth, I'm sure you know that, but saliva contains enzymes that prevent pathogenic bacteria from multiplying. The GI tract. Now, the stomach has a lot of acid, and that will kill a lot of your bacteria. The intestines have a lot of resident flora, and left to their own devices, they'll sort of crowd out the bad bacteria. And then your genitourinary tract, your vagina, a woman's vagina has a lot of acid, again, which will kill most bacteria. And there's a lot of normal flora in the vagina that crowd out yeast, crowd out other more harmful types of bacteria. The bladder is normally sterile. The urethra, we already talked about this in urinary elimination, in women is very short, but it's felt that the flushing action kind of prevents the skin flora that's on the meatus from ascending. So that's why it's important, when we tell people right after sexual intercourse they should get up and urinate, it's to flush out the bacteria that might cause that UTI. Okay, so now we'll move on to secondary defenses. Now your secondary defenses are non-specific. They're not like antibodies that only fit one organism. But what happens if the primary defenses are not enough? If the microorganism makes it over that wall, the secondary defenses are just going to kill whatever comes in. And so we have phagocytosis. And phagocytosis means that the phagocytes or white blood cells destroy the invaders. White blood cells are a big component in pus, and that's what gives it its color, that whitish green color. but white blood cells are considered a secondary defense. They're not specific, they're not antibodies, but they do destroy a lot of bacteria, and hopefully that's what you need to have happen. When your body senses that there's been an invasion, what's going to happen is the body's going to release its white blood cells towards the, they're going to come to the local area. Now your bone marrow is going to decide to produce and release more white blood cells into the circulation, and your white count's going to go up. And what you're going to see first when the white count goes up is immature white blood cells. And for reasons that are more related to the way the paperwork was laid out, it's called a shift to the left when that happens. And it just, when you see it or when you hear somebody refer to what's called a shift to the left, I'm going to put that up here. I don't want you to worry about it in terms of exam 1 content or the final exam. It's just something you might hear people say. There's a shift to the left. And what that means is body is making more new white cells to fight infection. So you know the body's mounting a response. And sometimes that response is effective and sometimes not. But when we see it, a lot of times the docs will, or providers will look at that and know. And there's no shift to the right, by the way. If anyone tries to convince you there is, they're playing with you. It's a shift to the left just means, back in the day when we did this stuff on paper, the new white blood cells, okay, the baby white blood cells, used to be on the left-hand column. And so when people looked at the report and they would see the higher numbers in the left-hand column, they knew that this was the body fighting infection. So that's what a shift to the left is. And like I said, if other instructors ask you about a shift to the right, they're just playing with you. They're probably just laughing to themselves the whole time. But that's phagocytosis. And then we have the complement cascade. Do not make yourself nuts trying to understand the complement cascade at this point. It will make more sense to you later. But basically the body sends out chemicals to get other things to happen. It makes the blood vessels a little more permeable so that the body's defenses can get through, so the white cells can get through and fight more effectively. The other thing we have is the inflammation response or inflammatory response. Now the inflammatory response is the body's defense, or it's a secondary defense against an invader. Sometimes inflammation is not related to infection, but when we're talking about infection, inflammation is almost always the body's response. So some key characteristics are going to be pain, heat, redness, and swelling. And let me kind of give you some reasoning for that. One of the things that happens with the inflammatory response, it's a chemical response. Histamine's released and some other chemicals, and their basic job is to make the blood vessels, the capillaries at that site, more permeable so that more blood flow can get to that area and bring all of those infection fighters, the white blood cells, oxygen, to that tissue to promote healing and to fight the infection. So what you get is an increased blood flow, so the site gets swollen, there's more blood down there, it gets red and it gets hot because there's a lot of blood flow to that area. The swelling causes pressure on the nerve endings, and that's what causes your pain. Now severe inflammation can lead to inability of the affected body part to function. Now one of the things we said, the inflammation response does include activation of white blood cells. So what you might see in addition to those symptoms is drainage. And that drainage will have white blood cells in it. It'll have a whitish green color from the white blood cells, and that's what's called pus. So you might see purulent drainage as a result of the inflammatory response coming from, say, an incisional area or any other like infected kind of wound. Very often that purulent drainage has a foul smell. So tuck that away when we talk about assessment. That's one of the things that's going to, set the alarm bells going off. If you see that on a dressing or, anywhere where there's impaired skin integrity, you're going to know that there's an infection. Now we're just going to have a word about fever as part of the secondary defenses. Fever is defined as a temperature over 100.3, and every textbook will give you a slightly different number for that, but that's what we term a fever. 99 degrees is not a fever. It might be a mild elevation in temperature from that person's baseline, but 100.3 to 102 is considered like a low-grade fever, and that's a good thing. That fights the infection. It keeps it from multiplying, and it also activates a lot of the factors that will help fight the infection. So we don't always want to treat it. If we do have a fever that's high enough to cause brain damage or death or trigger seizures in somebody, we have vulnerable populations that might need fevers to be treated. So what we would do is give them acetaminophen, but we're talking really temperatures under 102 don't necessarily need treatment. The reason that sometimes you'll give Tylenol in that instance would be for comfort, or if you have a vulnerable person, very frail elderly, very young children that are susceptible to seizures, pregnant women whose fetuses can be harmed by that elevation in temperature, you might want to treat little low-grade fevers, but most times the best answer to a fever is to let it run its course. That's what's going to help defend that person against the infection and help them get better quicker. Next we have our tertiary defenses, and I know you guys are all going to ask, do we have to know primary, secondary, tertiary? Not as a list of things to memorize, but I do want you to understand basic concepts so that you can apply them. So you don't necessarily have to memorize this, but I do want you to understand that antibodies are specific to whatever invader you're talking about. So specific to the antigen, which is that pathogen that's causing disease. It really responds to a protein on that cell wall. So an antibody-mediated response is sort of dependent on the person's previous exposure to that organism, whether through contact with a live organism or whether being vaccinated. The body's response is to form antibodies that will recognize that antigen and destroy it. So that's a tertiary. That's like a more complicated defense after that organism has gotten through the primary defense, which is, your skin, your mucous membranes, and then when the secondary defense, like a fever or the inflammatory response, doesn't work, you'll go to these tertiary defenses. So there's also a cell-mediated response, which will make more sense to you when you cover HIV. It's, your T cells, B cells. I don't want you to get too bogged down in that. So, with infection prevention, we could get very complicated and very in detail. There's a lot of material out there, but I think that's enough to give you a basic understanding of the principles of infection prevention. If you need to take a break here, go ahead. We're going to pick up with the nursing process next. Okay, so we're ready to apply the nursing process. Assessment for this is mostly going to rely on risk assessment, and then we'll talk about some signs and symptoms of infection that you should know about. Mostly we're going to assess for risk. What are some things that put people at risk for infection? Well, age, very young or very old. So your children under the age of 5 and your adults over the age of 65 are at risk, particularly if they're over the age of 80. But extremes of age do make a difference. We might have nutritional factors. If there's any kind of compromise in the nutrition, we have increased risk. Because the body needs all of those nutrients to make the components that fight invaders. Chronic illness, injury, like burns, really increases susceptibility, mostly because the release of, with injury we get the release of corticosteroids, and those compromise the immune system. Chronic illness, for lots of reasons. It depends on the nature of the illness, but it does weaken the body's primary and secondary defenses. If you have poor blood flow because of things like circulatory disease or diabetes, or if you have pulmonary disease, chronic pulmonary disease, if you have chronic illness, you're more likely to have an infection. So that's a risk factor that we can look at. We can look at alcohol and substance abuse, including smoking, and depending on the agent that the person is, whatever their drug of choice is or whatever they're using, it has different effects. Alcohol obviously can lead to decreased nutrition status. It interferes with the absorption of the B vitamins, which are important in immunological functioning, plus people who drink a lot tend to not eat very well. and so they're at risk for that, and then it leads to different issues. If you're, depends on what stage of alcoholism you're in, but if you're severe and you're at the end stage, your hygiene is probably fairly poor and your overall health has suffered. Substance abuse, different drugs cause different problems and different routes of administration. For example, if you're an IV drug user, you've created a portal that goes right into your bloodstream. So you're at risk for hepatitis B, hepatitis C, HIV, and things like bacterial endocarditis, or you might get a bloodstream infection with staph. So those are some things that you might be at risk for. And smoking paralyzes a lot of the natural defenses in the respiratory system, like the cilia, and can lead to increased mucus. Again, you're looking at that petri dish effect. So those are some other things. And then, of course, we have invasive procedures. A lot of the things that we do to people, they might be necessary to promote health from other factors, but if we're putting a catheter into somebody's bladder, which is essentially a sterile cavity, we run the risk of introducing microorganisms into that sterile cavity. Also, the longer a catheter stays in, the more the chances that bacteria are going to ascend. So we have to watch people who are at risk because of invasive procedures. Especially we want to watch people who have had surgery. For multiple reasons. Number one, they have an incision, so there's a break in the body's first line of defense, which is the skin. And then they have, respiratory secretions that are a little bit more difficult to mobilize because of anesthesia, if they've had general anesthesia. And also if they have an abdominal or chest incision, it hurts to cough, so you might not be able to mobilize secretions. Again, you're looking at a petri dish effect. So there's that. And a lot of times we have those urinary catheters that are inserted prior to surgery, depending on how long the case is and what the nature of the procedure is. And those people always have some kind of venous access. And, they're also recovering from a major stressful event, so their body might be a little bit compromised by the release of corticosteroids. So surgery, watch your post-op patients. They are at increased risk. Stress definitely interferes with the body's immune functioning. So people under increased stress, you might notice yourself that you're more likely to catch colds when you are experiencing a lot of mental or emotional stress. Any kind of physical stress also. And the reason for that is very simple. Again, we're looking at the release of corticosteroids. It's part of the stress response, which I'm not sure if you've had that content or not. Doesn't matter. Just know that when people are under stress, they have a higher risk for infection. So there's that. And then we have medications. There are certain medications that have various effects on the immune system. For example, even your NSAIDs, because they reduce the inflammatory response. Think about what NSAIDs are. And we're talking here about aspirin, ibuprofen, naproxen, drugs that you might be more familiar with because some of them are over the counter. It's a non-steroidal anti-inflammatory drug. And anti-inflammatory means it impairs the inflammatory response. And remember, the inflammatory response was the secondary defense against infection. So those medications do slightly impair the immune system. Steroids, corticosteroids like prednisone, have a very negative impact on the immune system. Other medications we give specifically because they sort of deactivate the immune system. For example, medications that we give to transplant patients. We don't want them to reject an organ, so we give them like Sandimmune, which is cyclosporine, that kind of paralyzes the immune system to some extent. And then your chemotherapy agents for cancer can also do that. So do you need to really memorize these things? No, but if I give you a scenario on an exam about a patient, you should understand that there are things that put them at risk. I'm going to put one more thing up, and it's an important one. So any break in the body's first line of defense, and here we're talking about impaired skin integrity. So anybody who's got a wound of any sort or any break in the skin is at risk for infection, and this is when you're going to assess that risk. Now, let's talk very briefly about the signs and symptoms of infection. There should be, any of you who've ever had an infection of any kind will recognize them, and these are just general responses. Every disease, every individual infection has its own set of signs and symptoms, and we can't cover them all here. For example, when we covered urinary elimination, we talked about how a urinary tract infection has frequency, burning, and urgency as its main symptoms. And we could go on and on about that for a long time, but you'll get that content later, so we're not going to linger. What we are going to talk about are some systemic signs of infection. So first would be fever, defined as a temperature, core temperature of 100.3 or greater. Another one you're going to see, increased heart rate and increased respiration. So tachycardia and increased respiratory rate. Very common with infection. And then we can look at signs and symptoms of inflammation, pain, redness, heat and swelling if it's a part that we can easily visualize. And then we can talk about our lab findings. So give me 1 second to get those up here. Okay, so here are your lab findings. You don't have to memorize these. Understand them, because when you get to clinical, you're going to be looking at lab reports and you're going to be using that data to get a more complete picture of what's going on with your patient. But you'll notice I didn't put a star next to these because it's not something you're going to see right away on exam 1 content. It becomes important later when we talk about musculoskeletal. We'll talk about some things that you'll see on your lab reports, and it becomes important in other areas of content. But for right now, just kind of take it in. You don't have to take extensive notes, but just kind of try and understand the concept. So one of the things that happens, we talked about how white blood cells are the body's responders in an infection or to inflammation. It's sort of one of the first things that happens. The body sends out these white blood cells. When we do a complete blood count or a CBC, one of the things we get is a white count. So you're going to get to know your normal numbers. We're usually looking at about 4,500 to about 9,000, depending on your reference range. Every lab reports out a little bit differently, but it'll be in that ballpark. Anyway, when you have an increase in white counts, sometimes it's stress and inflammation, but most of the time it means infection. And one of the ways that we can tell that it means infection versus stress and pain and inflammation is we look at what's called a differential. So a CBC with diff will take all the different red counts and all the different white counts and split them off into all the different subtypes of cells that there are. Again, don't get too fancy. I'm just giving it to you so you kind of understand it, because you'll hear terms in clinical. So neutrophils are your first responders. They're like the front line of the white count. Okay, when we look at the neutrophils in a CBC with diff, we separate the neutrophils into bands, and those are the baby white cells, the baby neutrophils, and segs. And segs are segmented cells. Those are mature. As the cell gets bigger, it has segments. So those are mature neutrophils. So when we look at the neutrophils, we're looking for the number. Because other white cells can mean allergy, they can mean different things. But when we look at the neutrophils, the bands are the babies. So what happens in an infection is that the body sends the white cells that are in circulation to the site or source of the infection first. Then the bone marrow says, hey, I think we need more of these guys. And it starts cranking out these little baby neutrophils. They're still bands. So when your ratio of bands to segs is high, you have more babies than you have grown-ups, it means the body's mounting a response. And we call that a shift to the left or a left shift. And people always get confused. Well, why is it a left shift and is there a right shift? Okay, so when we used to do lab results, we would have columns for these different cells. And when we had neutrophils, the bands were on the left and the segs were on the right. So when we see a shift to the left, it means that we have a lot of these immature neutrophils. It means the body knows something's wrong and it's responding. So that's what we're reading. If, let's say, you go to clinical one day and one of your instructors winks at you and says, can someone tell me what a shift to the right is? There is no such thing, because what happens is the body just gets normal. The neutrophils will just normalize. So there's no such thing as a shift to the right. There's a shift to the left. And like I said, it was from the old days when we reported things off on paper, and there was a column on the left for bands. That's what that is. It means the body's saying, whoa, something's wrong here, and all the bells are going off. It's an alarm. The body is sounding an alarm that there's an infection. Other lab things that you might see The ESR, or erythrocyte sedimentation rate, this is something that increases with infection. It can also increase with some inflammatory disorders, but ESR can go up with infection. And then we look at cultures. We do urine cultures, blood cultures, wound cultures. You can do eye cultures. You can do cultures of any kind of drainage that the body can make, stool cultures. And a culture tells us what's going on at a particular site. They take about 2 days to result. It's very important when you collect a culture to keep the culture medium and whatever you collected the culture with sterile. Because if you contaminate it with other organisms, you will never know what was growing there to start with, and you will never know which agents are effective against it. So you need to make sure that when you collect a culture that you use principles of asepsis. There's one more test that we can talk about if you want to know more, because you might see it. And it's C-reactive protein, or CRP. And when that's elevated, that's a marker of inflammation. So when we see it in conjunction with all these other labs, we know that we're dealing with, the body's mounting a defense against something. So that is enough really for assessment. That's a pretty big chunk of time, but we'll move on to the rest of the nursing process. So we can go through the rest of the nursing process relatively quickly. There's really only one non-diagnosis that is specific to a patient's risk for infection, and there it is, very obviously, risk for infection. Where it gets more specific is in your related to factor. Now, just a word about when we do not use risk for infection. We don't use it for every client who's in the hospital, even though theoretically, just because they are in the hospital, they are at increased risk because the bugs we have here are worse than the ones you see in the community or at home. We're really looking at patients who have increased risk factors. For example, risk for infection related to presence of urinary catheter, risk for infection related to surgical procedure, risk for infection related to poor nutrition, on and on. But we would target the related to factor in our interventions. Now, of course, when we're planning and we're identifying our outcomes, usually we're going to put something like client will remain free of signs and symptoms of infection throughout admission. And that is a specific, measurable, realistic, time-oriented goal that we can use. And obviously, everybody should know what the signs and symptoms of infection are, and we kind of already talked about them, so I'm not going to labor that to death. Now we get into our interventions. Things can get a little more specific. As I said, we kind of tailor it to what's going on with that patient, but give me 1 second, I'll put some things up. So in terms of our interventions, I made a list for you guys. If you want to take a screenshot or take a note and stop the video for a minute to write stuff down, that's fine. If not, just listen along and take notes as you go. The first thing that we're going to do is make sure that our environment, our hands, our equipment is all as clean as possible and that it's appropriate level of asepsis. So if it's medical asepsis that we need, which is appropriate in most cases, we're going to make sure that we have clean hands, and that we're going to use our alcohol-based rub or our soap and water, depending on what's appropriate. C. diff, remember I said, has spores, can't be killed by alcohol-based hand rubs, so we're going to use soap and water. If your hands are visibly soiled with blood or other body fluids, you're going to wash them with soap and water. Otherwise, alcohol-based rubs are a very good alternative. They can get sticky after a little while, so maybe after every third use you want to wash with soap and water again. It's fine. But you need to clean your hands, and we've already talked to you about, or you've seen it on ATI, about when that needs to happen. Before contact with any patient, you wash in on your way into the room. Anytime you have touched something soiled, or anytime you take off gloves, you're going to wash again or perform hand hygiene again. On your way out of the room, you're going to perform hand hygiene. So those are some times when you're going to clean your hands. Of course, to keep yourself healthy, you're also going to clean your hands before you eat, if you smoke, before you have a cigarette, anytime your hands are going to come in contact with your face, after you use the restroom, all those things, which we already know as common sense hygiene. Keeping the environment clean is important too. So you want to keep that client's room as clean as you can, and that will minimize pathogens, and that will usually involve, if you're in a hospital or in a nursing home or some other healthcare environment, the use of an appropriate hospital quality disinfectant. And there are lots of solutions. Your equipment, like your stethoscope, your blood pressure cuffs, things like that, also need to be cleaned. And you need to follow the directions very carefully on the cleaning equipment. If it's a wipe, it should tell you what the dwell time is, that surface has to be left alone before it can be used again. If it's a solution, there'll be directions on that. Surgical asepsis is a little bit different. This is when we need strict sterile technique. For example, when you're in a surgical procedure, a nurse doesn't perform them, but we do assist. When you're doing anything invasive to a client, for example, inserting a Foley catheter, when you're doing a dressing change and you are going to have contact with an opening into the body, you don't want to contaminate it, so you use strict sterile technique. And sterile means there are no organisms, not just no pathogens, no organisms at all, and you're going to follow the rules with sterile field. You learn a lot about this in perioperative, and when we teach you different procedures that use sterile technique. So that's surgical asepsis. Client teaching is also a very important thing. We're going to teach clients about hand hygiene first of all, because that's probably the most effective way to prevent illness. So hand hygiene is important. Teaching them to recognize signs and symptoms of infection before it becomes life-threatening. So for example, if you have an elderly client, teaching them to recognize signs and symptoms of a urinary tract infection before they become septic. So that's important. Teaching them how to promote their overall wellness to support the natural defenses. So if your client's at risk for infection because he's a smoker, you're going to target smoking cessation. If your client's at risk because of poor nutrition, you're going to talk about nutrition. If they have sleep and rest needs, all of these things contribute to your overall natural defenses. Stress reduction, all those factors that we talked about. And now you're also going to talk to your clients about immunizations, because immunization is very important to protect against vaccine-preventable diseases. So we depend on herd immunity. I know you've heard this before. And when some people choose not to vaccinate, it puts other people who maybe are vaccinated but didn't make the antibodies because their system won't do that, puts them at risk, because then there are more people with the illness in the environment and they're exposed to more pathogen. So we talk to people about immunization as both a personal and a public health issue. We're also going to use, in order to prevent transmitting pathogens from a client who is ill with an infection to a client who is not, we're going to use our different precautions. Standard precautions are what we talk about: hand washing, use of gloves, disinfecting things. That's our typical, every patient has the right to be kept safe from infection with these things. So you're always going to use gloves when you're coming in contact with blood and body fluids to protect yourself and to protect the patient in the next room from getting whatever organisms from the patient you're dealing with. By the way, clean gloves that you put on to perform patient care protect the healthcare worker, not the patient. Sterile gloves will protect the patient. What that patient in the room is depending on is your hand hygiene before you put those gloves on. If you contaminate that box of gloves because you didn't wash your hands, then every person who walks into that room is going to grab contaminated gloves and touch that patient. So really, I can't stress enough that gloves are not enough to protect the client while you're giving care. And you can't wear gloves from one room to the next room. It doesn't work that way. Don't take your gloves out into the hall. The gloves protect your hands from coming in contact with pathogens. And you still have to wash them when you take them off. There's always the chance you may have contaminated yourself with a few pathogenic bacteria. So that's important to remember. Those are your standard precautions. Standard precautions also include, if you feel that you're going to get splashed with blood or body fluids, or if that is a likely occurrence, you will wear a gown and mask and possibly an eye shield, depending on the nature of the exposure you anticipate. It also includes disposing of waste properly and disinfection of surfaces. Next, we have contact precautions, and there can be different reasons for putting people on contact precautions. It involves an infectious disease that is spread by direct contact, for example, MRSA, methicillin-resistant Staph aureus, or C. diff, which is Clostridium difficile, an intestinal bacteria that overgrows. And when we have a contact precautions, what we normally see is a patient in a private room. We limit or restrict their movement so that they can't walk around the unit. There should be a sign on the door that warns people not to enter without proper protective equipment, and you should have that equipment right outside the door on a cart. The person should also have dedicated stethoscope, blood pressure cuff, anything non-critical. You don't want to be taking things in and out of the room that might be, a reservoir for pathogens. And make sure when you doff your equipment, you're being very careful not to get the organism on yourself. And again, you do hand hygiene after you're done with that. And if it is something like C. diff, you're going to use soap and water instead of the alcohol-based hand rubs. Now, CDC does like alcohol-based hand rubs. Generally better than soap and water, except when you're visibly soiled or when it's C. diff, because it does kill the organisms more efficiently without damaging the skin. And it's handier to have at the bedside when you really need it. But in that instance, you are not going to use an alcohol-based hand rub. It's not effective against the spores that C. diff has. Next, we have droplet precautions. And droplet precautions we can see in certain illnesses that are spread by sneezing, coughing, talking, and that would include things like measles. Now, droplet precautions include keeping the patient in a private room. If you can't keep the patient in a private room, you can put them in a room with somebody who has the same exact illness. You want to make sure that you're wearing a mask if you're going to be within 3 feet of the client, and you want to restrict their movement to within the room. You don't want them walking in the halls. If you have to transport them, you want them to wear a surgical mask. Now, airborne precautions are a little bit similar, but remember, an airborne disease is more dangerous than a droplet-borne disease because a droplet-borne disease can only travel as far as that person's oral secretions. So as far as they can sneeze, cough, whatever. Whereas airborne precautions can get into the air and infect people at a longer distance. And so with airborne precautions, we want to keep people in a negative pressure room if we have one. And most units have one room dedicated to that. You may have to wear an N95 respirator mask to protect yourself from getting whatever disease it is. And usually with airborne diseases, we look at things like tuberculosis, and there may be others, but we want to also, if we have to transport that patient, put a mask on them as well, so that they don't spread that disease out in the air. And when that patient is done with that room and or transferred to another room, we want to take down all the linens, all the drapes, everything, and thoroughly clean that room to get rid of all the airborne particles. Now, protective isolation is also called reverse isolation, and this is for a client who is immunocompromised. In this case, we're not worried about transmitting the client's illness to others or to ourselves. We're worried that this person doesn't have the right immune factors to defend themselves against anything. Clients that might be on protective isolation include clients with burns, clients with leukemia, clients on chemotherapy, people who are at extremely elevated risk for infection. And some of the things that we might do are put on sterile gowns, sterile gloves, a mask before we enter the room, almost like a surgical asepsis, so that we don't shed any of our organisms onto these people. You're going to disinfect the room very regularly, and you're going to restrict the flow of visitors. This is not the place where you want everybody and their brother walking in the room. And anyone who does come in should be monitored for good hand washing and for donning of the right equipment to protect that person. And so those are some things that we do as far as maintaining our precautions. Now, as we move along in your coursework, we're gonna revisit all these concepts when we talk about when to place a Foley or how to manage a central line, or when you talk about diseases of the immune system or different infectious illnesses. We'll kind of revisit some of these, but your general evaluation is going to go right back to your assessment. Did the patient remain free of signs and symptoms of infection? And how are you going to know that? Well, you're going to have to continually assess them. Do they have any changes in vital signs? Are they having a fever? Do they have elevated white count? Do they have tachycardia? Increased respiratory rate? So you're always going to be monitoring signs and symptoms of infection. Now, if your related to factor was about their IV site or their Foley catheter, obviously you're going to monitor those specific things more carefully. But that's really about it for infection. We're going to pick up next. I'm going to break up the video a little bit so that you can take a break. and then we'll go into general safety with a special emphasis on falls prevention. Okay?